round with Mr. Cooper for 5 minutes.
Thank you, Madam Chair. To Dr. Neufeld, in the last panel, Sarah Lawley from Health Canada cited the guidance from the Canadian Psychiatric Association on evaluating irremediability and managing suicide risk as evidence of readiness for the expansion of MAID for mental illness. As the chair of the Association of Chairs of Psychiatry, can you speak to whether this guidance represents a consensus amongst chairs of psychiatry?
It absolutely does not represent any consensus amongst the chairs of psychiatry. In fact, the chairs of psychiatry and the majority do not support the expansion of MAID. In fact, this guidance document has just been published at the very end, the very last day of March. It's not peer-reviewed. And certainly none of us, to my knowledge, were asked to even participate in the process. So it doesn't represent a consensus.
And, it's my understanding that there were 8 members who worked on the guidance, all of whom were self-selected. Do I have that right?
I can't speak to how they were selected, but we do know that some of those members are very clearly, have been from the outset very interested in expanding MAID. Yes.
And so on the issue of consensus, would it be fair to say that to the degree there's a consensus, it's a consensus of these 8 individuals?
I would imagine so, yes.
Okay.
Yes.
Now, looking at the guidance, at the very start, there's a disclaimer that states, quote, "This guidance is not intended to be interpreted or to be used as a standard medical practice." What is the significance of that disclaimer?
Yes, it does make it hard to know how one would decide on how to implement this very final solution in patients. I didn't mean it that way. This very difficult to retract kind of medical decision based on these guidance. Yeah.
Okay. Now, you noted in your brief to the committee that the guidance offers no substantive criteria for determining irremediability. Instead, as you just noted, it copies and pastes Health Canada's model practice standard, which instructs assessors to consider prior treatment attempts, including their duration, intensity, and outcomes, as well as illness severity and duration. Now, you cited an example of a patient, and you also noted in your brief that psychiatric disorders follow non-linear trajectories, that patients frequently improve after years of severe illness, and that treatment resistance does not establish non-recovery. Do I have that right?
Yes.
Okay, so given that, is it fair to say that the factors set out in Health Canada's model practice standard that are copied and pasted into the guidance are not suitable or not appropriate for assessing irremediability in the context of mental illness?
Yes, I believe so. It is really hard to prognosticate based simply on people's history as to whether there are things that still should be tried or things that could still be helpful to somebody.
Now, you further noted in your brief that the guidance provides no clear instruction regarding distinguishing between a rational request for MAID and one motivated by suicidal ideation, and that instead of providing clarity, could actually create conceptual and clinical confusion. Can you elaborate on that point?
Well, I think the patient that I was telling you about really illustrates that. He was not impulsive. I think what I get from this document is that it's that impulsivity that we're warned against reacting to with MAID. In fact, that somebody who's planning to hurt themselves in the next little while, they are not eligible for MAID. But the problem is, as my patient demonstrated, that enduring, stable wish to die might be part of the illness, as it was in his case. Yet that would be considered an appropriate request for MAID.
So to be clear, Dr. Neufeld, is it your professional position that the CPA guidance does not constitute evidence of so-called readiness?
I don't believe it does. No, it certainly doesn't help me understand how this would be implemented.
And Dr. Coelho, is your position the same on that point?
That was perfect timing. Thank you very much. We will now go to Ms. Jessic for 5 minutes. Mr. Maloney, apologies. Mr. Maloney for 5 minutes.
Thank you, Madam Chair. Thank you to the witnesses for being here this evening. Dr. Gamache, I'm going to start with you. You started your remarks, and I think I wrote it down correctly, by saying this is really only going to affect a small number of people. Why is that relevant?
Because it's clear for us. It's going to be for people with very serious mental illness that have dealt with it for a long time. That means 3% of the population for very serious mental illnesses that have been followed for many years. I've been working for 27 years. I probably wouldn't have accepted this request in more than 2 of my patients over the course of those 27 years. So it's really a very minimal number of patients.
It makes no difference to me whether it's a small percentage or a large percentage. The issue we have to deal with is getting it right. And it sounded to me like you said that to give me some comfort in making my decision. So with respect, I think it's an irrelevant factor. My second point is you said you can always determine irremediability. You made that statement very clear and very decisively. My question is not to you, it's to the other 2 panel members. Do you agree with that?
No, I don't think I know how to determine irremediability. I don't know how to be absolutely certain someone cannot be helped.
I think the evidence does not show that we know how to predict irremediability in mental illness. And I have seen many patients that I've suffered with for years and years in the hospital and out who have recovered. And I would never have guessed it.
Thank you. So my dilemma in addressing this issue is I have to make a decision along with my colleagues around this table and make some recommendations. And those recommendations have permanent consequences. How do I do that when the 3 of you can't agree on the core issues? How do I, make a recommendation that we can go ahead with this if the 3 of you can't agree and many others in your profession cannot agree? Dr. Gamache, let me ask you that.
In my opinion, psychiatry and mental health, suffering, those are difficult things to precisely measure. I would be surprised to see that physical illnesses are much more precise all the time. For instance, in cancer, MS, Parkinson's, well, there's been progress, but it's not completely precise. So I think there's a clear dichotomy being made between physical and mental illnesses, but in my opinion, that doesn't necessarily respect the changes in the patients. But I will admit that it's a really difficult decision for parliamentarians. We're not saying it's simple. It's a difficult decision. But that said, if we say MAID is care, but then we decide that a small part of the population isn't eligible, and maybe that population already doesn't have access.
Interrupting, but I have limited time. Thank you for acknowledging that it's imprecise. That's my main point, because until I am given comfort and that there is precision, I can't responsibly make a recommendation that we can proceed with this. And that's the dilemma I'm facing. So I understand your commitment to the issue, and I understand, as you pointed out, the obligation you have to patients, and they should not be treated as second-class citizens. But I'm not sure that everybody in the profession is held to your standard or lives up to your standard, because we've had discussions tonight and previously about doctor shopping and jurisdiction shopping. And until I can be assured that everybody is as certain about things as you are, I'm just not comfortable. Is that a fair opinion or fair conclusion on my part, in your opinion?
Okay, very briefly, s'il vous plaît.
When MAID came for physical issues, there were doctors with conscientious objections that were not comfortable with MAID for physical illnesses. There are people in hospice care who
can't medically reach that conclusion. That's the dilemma.
Okay, I'm sorry, Mr. Maloney, time has expired. Thank you, Doctor. And we will now go to Monsieur Thériault pour 5 minutes.
Your microphone, please, Mr. Thériault. Well, I hope that won't eat into my time. Too long working remotely today. First off, Dr. Gamache. How do you see the consensus or lack of consensus in Quebec among your members, your own members? I'll start. A few years ago, rather, in a poll, more than 50% of psychiatrists felt comfortable with preparing for MAID for mental illness. That said, we have to see how it'll change, but many psychiatrists in Quebec already participate in evaluating MAID applications. Anything to add? The reason why we don't have numbers, well, it's hard to evaluate. I'm a general psychiatrist. I've lived here for 20 years in a small town, and I've been treating patients for 20 years. It's hard to answer on behalf of all psychiatrists, but in my opinion, most of my colleagues would agree on a few points. Intensity of suffering, for instance. We can't question that it's a chronic illness. It's a level of suffering that's sometimes really, really severe and would be equal to that in physical cases of MAID. If someone is bipolar, they'll be bipolar for the rest of their life. It's irremediable. What can change is the impact of the illness. Some people will be favorable to following a treatment, as Dr. Neufeld mentioned earlier. That's wonderful. But there are people that have harder lives. And then there are people that will have really, really difficult lives. We're the ones who take care of those people. I see them on a daily basis. And I've seen them for years, people who unfortunately are not doing well and who have no hope. We also have to respect, for other health issues, people's autonomy or their ability to make decisions and their autonomy to decide what they want and what they want to do about their suffering. We have to respect that. My colleagues in Quebec and elsewhere in Canada are able to acknowledge that. It's not because it's a mental illness that it's different, like MS. There are people with MS who can live pretty well despite a very serious illness. And it's the same with mental illness. In my opinion, because we don't well understand neurological anatomy in mental illnesses, we don't want to give them access to MAID. I think on a clinical level, most psychiatrists in Canada are adequately trained in order to determine the factors that would lead to a MAID application. If they're not comfortable doing so, if they're really uncomfortable authorizing MAIDs, well, they still need to acknowledge the needs of those who are suffering. And when patients ask for something, one must listen to them, and one has to really do good work to see where we are. And I think we can do that in many situations. It's just like in the rest of medicine. 4 to 5% of doctors, or more than that, I don't know the exact percentage. In psychiatrists, I'm sure it'll be the same. There are people who will be more specialized in evaluating this issue. In your opinion, is there a lot of medical condescension or paternalism in psychiatry, like back in the day? when patients wanted to access hospice care, when hospice care wasn't favorably seen. I completely agree with what you're saying, yes. Medical paternalism needs to no longer have a place in our relationships with patients. What I've heard this evening, well, that seems like medical paternalism for me. We need to be with our patients to help them to make difficult decisions and help treating them, and to stop imposing our own values upon them. Are there any patients that will wind up in kind of endless hospice care? Worse than that, there are patients who will commit suicide because they're not listened. Whereas if we supported them, they wouldn't wind up taking their own lives. Thank you.
Alors, nous commencerons avec les...
We will begin with senators, with Senator Delphine for 3 minutes.
What was just said, do we have enough resources to provide proper support and to those that are in need of psychiatric assistance in Canada?
I'm not a health systems expert in the Canadian context. I can only speak about what I know in my own region. I think we could do a much better job of spreading the amount of resources that we have, certainly within the province of Ontario. I know that there are many regions within the province that don't have access. We're relatively rich in the Hamilton, Toronto area, so we should be doing better. But I think even there, it's very long for people to get care.
Of Quebec, but Dr. Coelho, are you of the same opinion?
Yeah, I mentioned that I take care of people who live in the lowest socioeconomic strata in Ontario where I work, and so my patients have to access food banks, and all of these things play into increasing their mental health suffering. They can often get a quick consult for psychiatry if it's urgent, but it takes 5 years to access the super specialized like ACT teams for complex care, which is not good enough.
Is it the same situation in Quebec? Access to resources and support, is that available, or is there a lack of resources? I think it would be the same throughout Canada, unless there are some really well-off pockets for some patients all over Canada. One might ask, and I can ask you, we need more resources for all kinds of things. I also work with young patients experiencing their first psychotic episode and people with borderline personality disorder. The question is, for those who are very sick, they often have access to adequate resources in Canada. Where there's a major issue is when they're less sick. People on the first line, they see their family doctor. There's a massive lack of care for people in that situation, even in the regions like where I am. Accessing specialized therapies for people with borderline personality disorder, we do it well, but they need more care. And it's the same in other spheres of medicine. Excuse me for interrupting you. Is there a danger that we will divert resources that ought to go to support in order to undertake MAID evaluations, and in a context of limited resources? Well, I can't answer that question, really. I don't know how many of MAID evaluations will take place exactly, but in my opinion, like my colleague, this kind of treatment, MAID, would really be reserved for a teeny tiny percentage of patients, really the most mentally ill patients. So I don't think that there would be many.
Senator Martin for the next 5 minutes.
Earlier in the previous panel, we heard that the government has not responded to the UN Committee on the Rights of Persons with Disabilities. But there's another report, the International Association for Suicide Prevention which released a statement against MAID for mental illness, and they're the leading global body dedicated to suicide prevention research and policy. So I'm wondering about this December 25 report, if there's anything that we should be aware of as we're looking at expansion, and has the government responded in any way? Are you aware of that?
IASP statement in December of 2025 said that there is actually interlap between assisted suicide and suicide, and we have to not forget that, particularly outside the end of life. They emphasize that mental illness suffering, we cannot know if it's truly irremediable, and that hope always remains, that prognosis is inherently uncertain, and that MAID should never replace mental health care. The UN CRPD statement was that we should repeal Track 2, as I mentioned, not expand for MAID for mental illness. But they warned that basically what we're doing is we're putting people at lives of risks when we're offering them death in the context of not good psychosocial care and community solutions. And they emphasize that autonomy alone is not a sufficient safeguard. People wanting something doesn't mean that it's good for them, and it can very much reflect therapeutic nihilism. Like, I am so suffering with this patient that I think it's better that we just end it for them. Am I just complying with their suicidal demand? And is that really accompaniment, or is it actually an abandonment? And then the other thing I'd like to just address that was raised is, okay, so some people might be very careful and only approve 2 cases, but will they be right in those 2 cases? They may well be wrong, and that's a big problem, even if you have somebody who's trying to do their best. And the government has not responded to either.
Right, and that was actually my second question about relying on trusting the judgments of all physicians. And I know you've been part of the Ontario MAID Death Review Committee, so whether that has been your experience, there are mistakes that can happen. And
I'm very disappointed with privileged commentators who say that the disability community trying to share their stories in the media are fake. That's not acceptable. We don't do that. But on top of that, we have these cases that are government audited cases that we have reviewed their healthcare charts and come up with, the cases are from the coroner. They're not from us. If you want to question our analysis, fine, but the cases are from the coroner. The other thing about that is that, CMAJ just published a research paper last month by Pursuit, also from the MAID community, talking about inter-assessor variability. It is wide. I'll give you one example. For reasonable, foreseeable natural death, some people consider it weeks and months. Some people consider it 5 years.
Okay.
That shows that there's no standard.
Thank you, Senator Martin. Senator Moody for 3 minutes.
Thank you, Mr. Chair. I wanted to ask, thank you for your anecdotal example, Professor, because it is that. It is an example of a single patient that bears no relationship on generalizability, actually. And so if I were to ask you a question that relates to that, it's a yes or no answer. Are you saying then that you believe that all individuals have the potential to get better from mental illness? Because that's the impression you give us. It's a yes or no. Are you saying yes or no, that you believe that all patients can get better?
I am saying that I cannot predict who will get better.
Thank you. I'd also ask you, do you come to this table as a person who supports providing MAID for mental health as the single diagnosis, or are you opposed to it?
Are you asking me?
Yes.
Oh, I said very clearly to begin with that I am
I'm
opposed to it.
making it clear for the record,
Yes.
because you have made a statement that others who sit on the committee for the development of guidelines were clearly for it. I want us all to be clear about where we stand. I just want to ask Dr. Coelho, as you walk through your examples of, you mentioned a number of incidents that you describe that are quite outrageous if they're factual. In fact, they are a clear violation of law.
They are, Senator Moody.
Excuse me, I would like to ask the question,
Sure.
if you don't mind. Please wait. Thank you. So if they are clear and they're factual, then they're a clear violation of law. have you reported any of these directly to the police or to your college on the individuals that were involved in these cases?
So there are some cases that the coroner is aware of as an investigated and taken over once I've pointed them out. There are some cases where my patients did not go through with MAID even though they were approved because I helped them put supports in place. And so I didn't feel there was any need to report. And that's what we're doing with the MAID Death Review Committee, is trying to have quality assurance and safety.
So in the MAID Death Review, just as a point, MD-RC case reviews are used to generate recommendations for MAID practice and oversight, not to determine wrongdoing. You don't examine things to the level and degree in which you would be.
Advisory only.
Yes, exactly. Can you then say, in the cases that you have
Senator
reviewed.
Moody, your time is up.
Thank you.
Senator Wallen, 3 minutes, please.
I'm going to ask our two witnesses here, are you familiar with the studies by Dr. Downer, what drives requests for MAID, structural marginalization driving medical assistance in dying in Canada?
I've written a response to that.
Okay, so that is evidence that people who, through your anecdotal evidence that you've provided tonight, or testimony, I should say, the evidence is to the contrary. It's not for lack of access to services or advice or palliative care.
Actually, Madam Speaker, the response was signed by, I can't remember the exact number, but tens or maybe hundreds of doctors
Well, I think
contradicting
this study
the
is
findings.
16,000 people, and there was 14 cases of where better services could have been provided.
I could be getting the study mixed up, I'm sorry.
Yeah. So it is all in some senses counterintuitive, but what the studies are saying really is that level of income or access to services is not a driver for MAID, and we've heard this evidence from others as well, it's more the well-to-do that have access. Let me go back to Dr. Gamache and perhaps Dr. Barbier-Morin, and I want to follow up a little bit on what my colleague Mr. Maloney was inquiring about, which is certainty. Of course, we'd all like to have 100% certainty in any diagnosis of any illness, whether it's physical or mental, but that is not likely in the human being and in the human condition. Have you got confidence, certainty in yourself that the decisions that are being considered, we don't have any real evidence, of course, in the question where mental illness is the sole underlying cause because it doesn't exist yet. But in the work of MAID, do you feel that people are balancing that? Doctors, people in your positions?
Absolument. Et c'est pour ça
Absolutely, yes. And that's why generally we consult with our colleagues. We speak in committees when there are patients with specific symptoms. And we do that very regularly in psychiatry. We consult with our colleagues, we consult about complex cases, and we do that without the shadow of a doubt. In any case, in Quebec, we've suggested a way to evaluate patients that have asked for MAID. Very often, a request for MAID will be an ask for help, a cry for help, and we'll treat it as such. When we know our patients, when we've known them for a long time, we'll ask what brought them here, how they got here, and we'll analyze that very thoroughly. And in cases when we said it's not possible because it's not and found solutions, well, opening up the discussion is the first step if we tell all patients.
la décision.
Merci, Dr. Gamache.
Thank you, Dr. Gamache.
No, we don't.
Oh,
or
sorry,
no,
Mr.
Senator Wells.
Senator Wells,
You're
sorry.
forgetting your colleague.
Yes.
Thank you for not forgetting about me.
3 minutes.
My question, just want to pick up with Dr. Gamache on that point that was being made in the question. So we've heard that some individuals say clinicians often disagree amongst themselves whether a person has decisional capacity. So can you walk us through what happens if two assessors don't agree a person with a mental disorder requesting MAID lacks capacity?
La question s'adresse à moi.
Is that a question for me?
Si on a deux évaluateurs,
If there are two assessors that don't agree, well, a committee must be consulted. Then different people will assess. That's how we evaluate complex cases, the same way with physical cases.
Thank you. To follow up, what will happen if a person who requests MAID has not had adequate treatment?
il va falloir qu'on passe.
In Quebec, well, then specialized psychiatrists will have to be consulted and will have to ensure that they've had adequate treatment. Someone with refractory depression who refuses electroshock therapy, well, then we'll have to decide that that person would not be admissible to MAID. It would have to be available, and it will have to be attempted for multiple years before having access to MAID.
Safeguard that is in place.
À notre avis, oui. Oui.
In our opinion, yes.
By the Canadian Psychiatric Association reflect good practice?
À mon avis, oui.
In my opinion, yes. Yes. We find that it's absolutely adequate.
Say that psychiatrists cannot distinguish between suicidality and a MAID request. How would you respond to that?
Je pense que c'est
In my opinion, it's simply to not understand the daily work of a psychiatrist that works with suicidality and suicidal ideation on a daily basis. And a psychiatrist can see if that request remains over time. So previous suicide attempts, suicidality, suicidal ideation, hope, what's happening with their loved ones, well, that's the daily work of a psychiatrist, and we want the MAID request to be done when patients are stable and not in a moment where they've lost control or autonomy.
See, there's 7
seconds, so
remaining.
we move on.
Okay, we'll go to round 2, and we have 3 minutes for Ms. Jansen.
Just a quick follow-up on what Dr. Gamache just said to the two witnesses here. Is there anything that says that someone has to have had adequate treatment before a MAID can be acquired?
In fact, it was my understanding that if the patient does not agree or is not willing to consider a treatment, a patient does not have to be compelled to try something.
Dr. Coelho?
In the MAID Death Review Committee 2024 second report, there is a case of a gentleman who receives MAID even though he went to a psychiatrist who suggested he could get MAID because he had a disability, and he died from MAID with his mental health and addictions largely untreated as documented in the case.
Okay. We've been told that refusing to expand MAID to mental illness is discriminatory, and yet in the cases that you've reviewed, there were many recipients living in poverty, isolated, without proper support. So I have to ask, is not offering death to people who need compassionate care a discriminatory response?
It's a very weird way to frame medicine because MAID has been placed in medicine. Medicine is based on population evidence-based medicine on risks and harms to everybody and patient safety. And so, for example, for an amputation, you couldn't just demand an amputation, right? You'd actually have to have clinical indications that would meet the criteria. It's not discrimination to not give someone an amputation. If they would do better, even if they're in terrible pain, if they would do better with compression stockings or revascularization or something else, then we wouldn't give them an amputation, and we wouldn't give them an amputation if it had no benefit to them at all medically, even if they wanted it. So this whole framing is off.
We're just so short on time.
Sorry,
I would like to pass my last minute over to my colleague, Andrew.
Dr. Gamache, Senator Wallen earlier had said we can never have 100% certainty on this. We have some disagreement even on the panel here today, as Mr. Maloney pointed out. In your view, what would an acceptable margin of error be for misdiagnosing and misclassifying as irremediable if mental illness is a sole qualifying criterion for MAID?
40 seconds.
I can't give you a specific margin of error, sorry.
Acceptable margin of error?
En fait,
Well, it would certainly be 0. One must ensure to have done everything possible for patients before accepting MAID.
But if we have disagreement here, is that not proving that there is going to be a margin of error greater than 0 if we proceed with this?
évaluer la souffrance, évaluer les problématiques psychiatriques.
Well, it depends on chronic psychiatric illnesses. It's true that there will be disagreements. Human beings are very complex. So yes, there should probably...
Life or death?
Okay, thank you. Oh, I see. Okay, so I will now ask the co-chair, and you have 3 minutes.
So I've got my other hat on now. Dr. Gamache has said that she thinks MAID for mental illness will be very rare. We've heard that for other people. Dr. Gupta, she talked about the requirement that you would have to talk to the family beforehand. You would have to talk to all treating physicians beforehand. You would have to have tried all forms of treatment. Quebec may want to implement a system which has those things in there. But Dr. Neufeld, Dr. Coelho, Dr. Neufeld, maybe I can ask you first, are those things required under the current legislation, all those safeguards?
They are not, to my understanding.
And you both, Dr. Coelho and Dr. Neufeld, you work, as I did as a doctor, with a lot of other physicians. Dr. Neufeld, you are chair of psychiatry. You train a lot of psychiatrists. Are all psychiatrists the same? Are all equally careful? Are all going to insist on all those precautions before acting? It seems to me there are some psychiatrists who very much believe that this is the right of an individual. It's their autonomous right, and they feel that not only do they not have to talk to the family, but if the patient refuses consent, that they cannot talk to the family, that there isn't a requirement of other forms of treatment. So do you think in practice that all treating doctors administering MAID would be that careful?
I think there's going to be a great deal of heterogeneity, just as you've seen in this committee tonight.
Are there, in your opinion, Dr. Coelho and Dr. Neufeld, are there some doctors who very much as part of a living make their living on administering MAID?
I would say that a lot of MAID clinicians are very careful and very good, but you have a group of MAID providers who do very high numbers, who do actually in public say that they have a very broad approach, that they take cases no one else would do, and that is concerning to me.
Dr. Coelho, have there been any cases, and I hear that there have been cases that have been referred by the coroner to the College of Physicians and Surgeons of Ontario, have any of them resulted in disciplinary hearings against the doctors involved?
I think only one. And that was at the beginning when a doctor made up their own MAID protocol and didn't bring a MAID kit. So actually there's been no ramifications for any of these other cases that I'm aware of.
So have there, to your knowledge, been other cases referred by the coroner to the College of Physicians and Surgeons?
No, being part of the MDRC, we don't have the privilege of knowing every case that's been referred. We trust that they have been referred, but we haven't been hearing of any findings despite these cases being public. And most of us feel that these are very concerning, even from the MAID community.
Why have the colleges, and I think Mrs. Tamara brought it up, why have the colleges not pursued any of these cases?
Okay.
It's a highly hard question.
Yes, actually, time has expired, so we do have to go to Monsieur Thériault. So, Monsieur Thériault, you have 2 minutes.
Thank you. Dr. Gamache, and Dr. Barbas-Morin. Earlier, you said it's not only keeping on going with treatments forever. Eventually, nothing works, and because one is no longer able to provide useful treatment, one will tell the patient, well, I can relieve your suffering the best that I can, but so you'll just have to suffer. And in your opinion, the danger is that rather than having a death that's not insufferable, the patient will suffer. If we open up MAID to this, to those with mental illness, could there be a positive effect? Could there be a positive effect for, let's say, detecting symptoms? Let's say someone asks for MAID, and maybe that'll allow them to acknowledge those symptoms. Response: yes. The patient can say they feel lost, they want help. Well, then we can evaluate everything that's happened. We can put in place a treatment plan. And I've heard many recent discussions, and there seems to be such a high standard for psychiatry, and then in all the rest of medicine. We're asking our patients to be evaluated by perfect clinicians with like zero margin of error to access that care. It doesn't make any sense, in my opinion. Psychiatry is more and more data-based, and all medicine is imprecise, and we try and do our best, but medicine is simply imprecise, like all other disciplines.
Second round for 2 minutes.
So for the senator, is it right back to you, Senator Martin?
Yes. My question is for Dr. Coelho, just in terms of the Ontario MAID Death Review Committee that you served on, like the lack of safeguards, like what concerns you about expanding MAID for mental disorders?
As someone had asked before about MAID for mental illness, I also am very concerned about MAID, Track 2 MAID. And, as for the gentleman from the AMPQ, I'm sorry your name, but there is a lot of uncertainty, even in disability at the end of life. And these psychosocial factors, they really do impact suffering, right? If someone can't work anymore, they're thrown into poverty, they lose their social circle, then those things actually increase despair, and then they drive hopelessness, and they increase wishes to die. So I'm really concerned that the safeguards for all people outside the end of life are just not sufficient, and especially because we don't have an oversight, as I was asked about, an oversight that's actually enforcing the actual standards and preventing drift, potentially of a very small group of MAID clinicians, but they're very dangerous because every life matters.
Dr. Neufeld, do you have concerns regarding the lack of safeguards that then if we were to expand MAID regime?
Yes, I do, Senator Martin. I have grave concerns if we expand to include mental illness because of the lack of safeguards.
I think I don't have enough time to do a third question per se, but I'll just use the rest of my time simply to say I did meet with the stakeholder from BC. He suffered an injury, became disabled. He didn't apply right away, but what he is facing legally, medically, and the fact that he's so concerned about others who are being offered MAID and are choosing MAID. So, and there's a lot of mental health involved in what they're going through. So I do agree with you in terms of your concerns regarding the lack of safeguards.
Thank you, Dr. Moody, for 2 minutes.
Dr. Coelho. And you raised the question of Track 2. So I was wondering are you aware of the following statistics? And I'm talking statistics here, not language like many and a lot. While MAID cases continue to rise, MAID cases for people whose natural deaths are not foreseeable i.e. track 2, actually fell in 2023 and remained extremely rare, 0.09% of deaths. Are you aware that 95% of those in track 2 with a self-reported disability receive supportive services? Are you aware that only 3% of track 2 recipients had previously been found ineligible for MAID, and there is no evidence of doctor shopping that lay behind these cases, as opposed to an example, a change in a person's condition being the cause? Are you aware that the prevalence of isolation or self-perceived burden amongst MAID recipients is either the same or lower than the prevalence of those reports in community dwelling or terminally ill people who do not seek MAID, suggesting that these factors are not drivers for MAID to any substantial degree? And finally, are you aware that MAID recipients are much more likely to live in private residences and less likely to be in residential care, long-term care, than those who die naturally? That many older MAID recipients live alone, but at rates that are very similar to the population average for their age. Again, suggesting that this is not a driving factor for MAID.
Okay, there's only 15 seconds.
Okay, I would just say that, you know, being white or wealthy or privileged doesn't mean that you're not vulnerable at the end of your life. The Health Canada report are all reports by MAID providers. Sorry?
Seconds are finished.
Okay, she did have a few more seconds. Just, did you finish your last sentence?
Fine.
Okay.
Time's expired.
All right. With that, thank you so much for your testimony this evening, taking all of our questions. We will suspend very briefly and go into third panel.